Last year, I lost my friend Katha, not to COVID, but to suicide. They were suffering from severe depression, but refused to seek clinical help due to their previous harrowing experience of being repeatedly harassed within the Indian medical system. Unfortunately, this is a very common story in the lives of many trans people in India. But most of us here might be aware about the global legislations and movements taking place for trans people and thinking, is India an exception? No, India is no exception. India also passed the Transgender Persons Protection of Rights Bill. So now the question is, how successful are these legislations in providing quality healthcare to trans people? That's where my dissertation comes into being. I question trans people's access to quality, inclusive, and affordable healthcare after the passing of Trans Bill in India. To address this question, I use a substantive rights approach framework. That is, I examine the actual ability of trans people to access healthcare. For that, I conducted 7 months of on site ethnographic fieldwork, doing interviews and group discussion with trans people from diverse backgrounds. Analyzing this interview and group discussion, I find that trans patients suffers due to the lack of gender-neutral wards and bathrooms within the public hospital. The bill had no provision on training doctors on the health needs of trans patients. That's why there were several reporting of fatal sex reassignment surgery, trans patients being victims of microaggression and discrimination. Clearly, this lack of accommodation and acceptance within the Indian medical system further deteriorates the mental and physical health of trans people. Additionally, my statistical analysis shows that poor, rural, differently abled trans people with lesser awareness had the worst access. More needs to be done. Beyond legislation, my dissertation, foregrounded in everyday encounters and exchanges of trans people, proposes a 5A healthcare accessibility model, that is, access as a function of awareness, availability, acceptance, accommodations, and affordability. If healthcare bills and health centers are developed according to this model, interconnected with one's class, gender, disability status, and caste based experience, maybe we could have saved Katha. Maybe in future we can ensure that patients like Katha seek for medical help and no longer commit suicide. Thank you.